Welcome to the Point of Medicine podcast, brought to you by learn.Neural Doctors Ann Hill and Ilana Guravich team up to take a deep dive into the art and science of healing. This podcast explores cutting-edge approaches to the autonomic nervous system and its role in organizing fascia for optimal health. Each episode features conversations with leading clinicians who are pushing the boundaries of medicine, uncovering new insights, and transforming patient care. Join us as we bridge tradition and innovation to expand what's possible in modern healing. Just a reminder, this podcast is for educational and entertainment purposes only and not intended as medical advice. Please consult your healthcare provider before making any changes to your healthcare plan. Join us and let's jump into the next episode.
Hi, everybody. My name is Dr. Ann Hill, and welcome to The Point of Medicine. The Point of Medicine is a podcast where we discuss all things neural injection therapy and other injection therapies, as well as any modalities in the medical world that have to do with connecting the fascial system with the neurological system. And we cover everything from physical ailments all the way to mental emotional ailments. And so without further ado, our wonderful guest today, Dr. Michael Gurevich. I'm going to have his daughter and my co-podcast producer, Dr. Ilana Guravich, introduce him.
Hi, I am very, very excited to have my dad as our first official guest on the podcast, partially because he inspired so much of my trajectory, but also because he has found this really incredible perspective or lens on psychiatry through neural therapy. Dr. Michael Gurevich is a board-certified adult psychiatrist and addiction psychiatrist. He did his residency training in Elmhurst Hospital in New York, Queens. He then proceeded to run a private practice, working in both the conventional system and then through the years, also discovering alternative medicine as a way for treating psychiatric diseases. He is exceptionally well-versed in both conventional and holistic ways of treatment. And, you know, I had the luxury of working with him in New York for a year. And what I saw is that he was able to be one of the few people who could get people safely off of medication. So we're really excited, especially since Dr. Michael Gurevich has this very clear perspective about psychiatry and interference fields.
Thank you. There is some sort of a noise there.
I hear it too.
I
What
don't
is
know.
that?
Yeah, okay.
What is that?
I don't know, but should we do that again? It's very easy to edit.
Okay.
So should I?
You
should I
can
do the
actually edit that noise.
Oh, completely. It's very easy to edit on.
Okay. Then let's just continue if we can do that.
You don't need to. Okay.
Did I get your bio? I'm going to say the bio again. Did I get it right?
Yeah. That's fine. Yeah.
Okay. Okay. So take two. I'm very, very excited to introduce our first guest, Dr. Michael Gurevich, partially because he is my father and he shaped my medical career very drastically, and partially because we are lucky enough to have somebody on the show who has this incredible perspective on psychiatric conditions, which we all know in clinical practice are, exponentially getting worse. And he has the ability to take people off of his medication. So he is a conventionally trained psychiatrist. He is both board certified in regular psychiatry as well as addiction psychiatry. He did his medical training at Elmhurst Hospital in Queens. And from there, he worked in the hospital for about a decade and then proceeded to work in private practice because he kind of was realizing that the pharmaceutical model is not actually fixing patients' diseases. And so through a lot of different turns and avenues in his work, that it kind of led him to understand the power of using neural therapy in particular to change people's psychiatric outcomes. And today, the conversation we want to really be having is how do we use this incredibly versatile tool for treatment of complex conditions like psychiatric conditions. So thank you so much, Dr. Michael Gurevich and Papa, for joining us.
Okay. Thank you. Thank you very much for such wonderful introductions. Actually, it's a privilege to be the first one on your podcast. And I know you ladies, of course, I know Ilana well and Anya quite well. And it is quite a treat to see how far you two advance in neural therapy and how much you are using it. And now your training program is one of the best. And in United States, we have only 3 training programs, and yours is the youngest, and I think the most, the biggest, the fastest growing one. So Congratulations.
We're also going to say that yours, because you also have a training program, is the most advanced. And that's honestly how both me and Anne have taken classes with the physicians that you bring out from Latin America and from Europe, because I think it's the only course of its liking in the country. So I also think our family's a little bit biased towards this injection-based protocol.
Whatever we're doing for family, we want to say, let's inject it.
So before we get started, will you just tell us, I gave a little bit of bio about yourself, but will you just tell us about yourself and how you got into medicine first and then neural therapy in particular?
So I come from a medical family. So my mom was a surgeon. My two older sisters went to medicine. So for me, it was kind of no-brainer. I knew from the age of 10 or so that I'm going to be a medical doctor. And then basically coming from emigrating from Soviet Union with Ilana, who was at that time 2 years old, and getting into residency and getting through all the exams and getting into residency was actually quite a challenge. And I was lucky to get into psychiatry, and that became the field that I kind of thought that was built for me. So I'm a sensitive fellow because I had a stuttering issue since I was a little kid. And that kind of made me more sensitive to many things. And I think it's a good skill in psychiatry to kind of to feel how your patients feel. So some disability turn into the positive one. And I think we all can do it. So, and when I started my psychiatry practice, it was, of course, all the medications and electroconvulsive therapy, because that was what we had at that time. And it was not working. I was in charge of taking care of patients with the substance abuse issues. And I would do my best to help them. They would leave the unit and they will relapse. And then I found out about this 5-point auricular ear acupuncture, and it patient began to feel better, and I would kind of, they would not come back. So I knew that something I was doing was right. So then I learned there is more point on the body, and I went into acupuncture. But as a medical doctor, very few of us do practice acupuncture, because somebody like Ilana and Anne, they go through the training, they know much more than I do in 300 hours. But it helped me to open my vision that there is much more in medicine than just giving medications and other stuff. Then in around 2000, I met one of the most important mentors, Dr. Dietrich Klinghardt, who taught multiple things. And one of them was neurotherapy. He's a highly innovative doctor and extremely bright, smart. So I didn't know anything about neurotherapy books at the time. And as a psychiatrist, when I began doing neurotherapy, I knew that it works. Didn't know that much at the time, but it did work. And then 10 years later, I found out that when I got my first neurotherapy book, that neurotherapy is contraindicated in psychiatric patients. And I thought, this is something crazy. So I continued to get my skills. One of the most important injections in neurotherapy was stellate ganglia. It's a ganglia on the neck. And at that time, the research was coming from the Veteran Administration that this injection was helping patients who were war veterans. However, nobody would teach me how to do it hands-on. Dr. Klinghardt didn't teach any neurotherapy courses hands-on. There was his student, excellent practitioner, Jeff Harris, but he was not teaching it as well. So it took me a couple of years and I wanted to learn it. So it took me a couple of years to find practitioners initially from Germany and Switzerland, Spain, to begin to bring to United States and to teach me, Ilana, and many other practitioners how to do it. And I began to refine my own skills, how to do this injection. And now I do it with a very small needle, half-inch needle, and I do it almost on all my patients when I do the neural therapy for emotional issues. And it's a very easy injection instead of relying on a very complicated kind of equipment and giving people long-acting local anesthetics, which can cause bunch of defects. So anyway, probably it would be for anybody who is interested in neural therapy. This is one of the sort of not a complicated injection to learn, and I would, I can pass my skill, but you already know how to do it. What I wanted to talk to you today is about the interference field, which can be caused by emotional stuff. So I'm first kind of talking about neural therapy, and so not everybody knows what interference field is, but this is kind of one of the most important thing in neural therapy, to know what it is. So, and it's an interesting thing how the technology, Anyway, interference field is one of the most important thing in neural therapy. Let's say the scar or the infection or the prior vaccination or any sort of issue on the body can cause this interference field. The teeth are very frequent kind of cause of that. And what's happening with the interference field, so it sent signals, kind of scar or whatever, sent signals to the brain responds, and quite often the response goes not to the place where the scar or whatever happened, but goes to a different place. And you can treat this pain which caused on a shoulder or whatever other place for as long as you want. Unless you resolve the interference field, this pain will not be resolved. So, and in neural therapy, that is the most important thing which most neural therapists kind of looking at. And that was what I knew and what I was doing for years. And another skill that Dr. Klinhart trained me in was a muscle testing technique, which he calls RAT, and basically it's the idea is if you touch whatever point on the body where there is a disturbance, your hand becomes weak. So in a simplistic way, it can be that way, but this technique, of course, have improved over the years, and I improved it in my own way. What was interesting when I began to work with the scars, and I would just find the scar and I would inject it, and at times people would suddenly go into strong emotional reaction, kind of remembering what happened. So that brought a question in my mind. It looks like every scar or whatever happened in the body has a connection with our emotions. Can emotions themselves cause interference field? So I will talk about it as well, because what if you combine both emotional work with the injections of the interference field? What do you get then? Do you get more reaction? Do you get reaction? Do you get no reactions at all? So my answer is that you get faster, number one, that you get faster resolution of the interference field if you ask patient before you go with the needle to whatever place where he complains about the issue. If you ask him to begin to tell you the story. What happened when whatever things have happened with him. And I'm going to give you several examples. So one of them, about 6 months or so, I had this interesting young man. He was 22 years old. He came, he worked in his family business. He sort of did not even graduate from the high school because he lost all his hair, and he lost all his hair several times, and the kids were making fun of him, so he was afraid to go to school. And he had horrible social anxiety. He didn't have any friends. He kind of was going back and forth to work, and that's all. So as I began asking him to tell his story, he told me that when he was 6 months old, his mother took him for vaccinations. And I just want to tell, I have nothing against vaccinations, but his mother took him for vaccinations. And after he got his vaccine at 6 months, he went into coma for 6 weeks or so. And basically, and after that, his life continued. But at 6 years old, his mom, who was a very diligent mom, took him for vaccinations again. And at that time, he not only went to coma, he lost his hair. And then at the age of 12, his mom took him for vaccinations again. At that time, he was 12 years old kid. He fought nurses, so it required 4 or 5 nurses to restrain him to give him vaccinations, and he's lost all his hair. Of course, at the age of 12, if you lose his hair, it's pretty difficult to be in school. And this was a pretty athletic, smart kid. Anyway, what was interesting, so when he came for the second or third time, I don't remember, when I asked him about the story, and to find the scar or find vaccination place, it's very easy. Doing either muscle testing exam or even light touching, and your hand will get stuck in the place where there is an interference field. So what was interesting, I gave him I just put my needle, and I put maybe 2 to 3 cc of procaine. So he had this violent reaction, screaming, yelling. It was, my goodness, I was afraid. I needed to kind of myself restrain him because it was so much screaming. I needed to tell my staff everything is okay. I'm not doing anything bad. And then he fall asleep I didn't know if he's conscious or not, because it was such a deep sleep. In half an hour, I wanted to wake him up because I didn't know if he's breathing even. Anyway, I had to repeat this injection several times. And every time, reaction was strong, but becoming smaller and smaller. So basically, I think I was able to get this such strong reaction and help him to relieve it, because he was coming every time I was asking him. He was coming with a different level of memories. So not only memories when he was 6 years old, but also memories of how the kids were scapegoating him, how he was putting enormous amount of efforts and money to get his hair back, how if anything would happen, he would lose his hair again. So it's a pretty interesting, pretty amazing case.
He kept coming back, so he knew that it was helping him.
Yeah. He's Another very interesting case which I had just 2 weeks ago, and this time it was 81 years old MD, who is a professor, who is now semi-retired physical therapist, who was this tall guy, Olympic champion at his time, even his 81 years old, but you can feel that he's pretty strong and energetic. Reason he was referred to another practitioner to me is because year and a half ago he had basal cell carcinoma, and they removed it in 3 places over a 2 months period, and then he developed horrible pain, which he characterized as 7 out of 10 or more. And the pain was pretty persistent most of the time, except when he would be engaged in either doing some sports or being at work or being engaged with people. Then he would sort of get distracted and not pay attention to his to his pain. Otherwise, it was there all the time. So I began to ask him about the story of what happened, and he was telling me the story, and I'm kind of looking for the scars. And with muscle testing, it's kind of easy to find out which scar is more important and which scar is less important. So he had about 4 places where it was basal cell carcinoma was removed, and there was 1 place on his shoulder where it clearly was much more important than the other places. So, and I decided, let me just focus on this place because that is the key. And I asked him what happened with this scar. And he's telling me, I went to a doctor. It was my 3rd visit, and so they found this basal cell, and he removed it, and then he began to put sutures, but somebody called him and he needed to leave. And the resident came, and the resident took over. And he's saying, and this resident, he didn't know what he is doing, and he was doing me so much pain. And I told, no, you're not allowed to do it, and so they called this other guy. He finished the job. And as I was doing it, he's coming with a strong emotional reaction. And this is the man who kind of does not express any emotions. To become Olympic champion, he had to fight his way through. He was telling, I never allow anybody to do anything to me, except I found out he has another scar from appendectomy when he was 6 years old. But no, I'm not allowing anybody, and I'm not taking any medications. This is guy against all the medicine, even though he's a professor and stuff like that. Anyway, as I did the injection, he began to come with this story about this resident, and then guided him through the imagery. You usually kind of, when people go through the story, you want to help them to resolve it in some way. So quite often, when something bad happened, the first stage of resolution is hate and anger at a particular person. So he was telling me, I am gonna kill this guy. I feel like I'm killing him. That is the first stage. And so I helped him to talk to this guy. I'm kind of, when you are next to the patient, you can almost like hear his thoughts. And I'm kind of tell this guy how much he didn't, how much it was difficult, how much you hate him. Anyway, all the negative stuff. But then after that layer is relieved, there is a next layer, and that is a more important layer to get the resolution and to get the compassion. So basically, the resolution is I guided him how to breathe through his whole body, out of this wound, out of his whole body, this whole negative energy. And then basically look at this resident again and kind of tell, listen, I understand you're just a resident, you don't know what you are doing, and I'm going to teach you how to do it, kind of to guide him through this second stage. And then he he fall asleep, and good, I could use other office. I didn't want to bother him, and then I called, in a couple of days, how is it going? And he sent me a message, thank you, my pain is 70% better. So uh, it's a nice kind of story.
Is your experience that they could have some of this relief without the emotional work, or is it vital to pair the emotional work with the injection, knowing that you're highly specialized in an emotional field?
Yeah. No, listen, for years, until I kind of discovered that second component, I did all the scars without the emotional component. So it can perfectly work without the emotional component. And I think it's fine. However, if you have a little bit more time or you feel like you can do it, I think you will do a good service to the patient if you just will add this component.
So just so I can, because I don't do this. Dr. Hill, do you do this?
Do a little bit with cranial. Yeah, sometimes we're talking people through stuff that they're processing. Yeah.
So what I'm hearing is before you inject, you find the scar, you test, you find that that's the one that is having a lot of charge, and you'll have them tell you a story about that scar. Is that correct?
So basically, I'm a psychiatrist. So my first interview is hour and a half where I need to get the story. I need to find what brings the patient to my office. I need to find, is there a trauma, is there infection, what happened? The psychiatrist who goes after after looking for etiology, I want to find the story. So in many ways, I already know what the story is. So kind of, or at least part of the story. And then basically when I focus on a particular scar, and the patient have many scars, and I've been thinking about it, is it only I as psychiatrist can do it, or you as medical doctors can do it? And will it take much longer time for you to add this element? And I think it's not going to add too much time if before you inject the scar, let's say the scar, whatever place you choose, you ask, what happened? And while you are putting the procaine in your syringe, you ask the patient what happened. And the patient is focusing on the memory of what happened. And while you are injecting, the patient feels pain, but he also has the memory of what happened with the particular scar. And the scar always has a memory because something have happened. It is particularly important for the highly emotional scars, like episiotomy scar, for example. I had these ladies with postpartum depression, and they have C-section scar, and they become depressed because quite often women plans for the pregnancy. They go through all the courses, how to get the baby. You remember that. So, and then something wrong happens and it doesn't happen. And that becomes a strong emotional component. It didn't happen the way I wanted to. So you see, so while you have this emotional component and you inject this episiotomy scar, you get strong emotional reaction. So just for you, ready, such reaction may happen. Nothing wrong with that. It adds another layer, another element, another way to help people to resolve it.
And how do you see that in your practice? How do you pair cranial with that?
With, a lot of times people can have these, I experience that too, where we'll inject the scar. I ask the questions about the scar, we'll inject it. And oftentimes there will be tears, or there will be kind of almost a feeling of going back to that time. And so I've tried to figure out how to train people in this, but I just feel like I get these like questions that seem to help facilitate, patients to be able to release some of this, And so, so then they're able to just process it a little bit better and usually feel a little bit more grounded after doing the cranial as well. So, yeah.
I know, and that you do a lot of work with women, and many women have this PTSD, post-traumatic state, because they were raped, or the sex didn't go well, or whatever happened, So I do see these women in my practice. I developed this method, trauma resolution therapy, kind of. That's what includes. And I would ask them to tell me the story while I am doing pelvic injection. And my goodness, they come with all those emotions, and they come with all those emotions, which I think help them then to get better. It may be my bias, but I think it does help them to resolve things. And
I have a story with a patient who was trying to get pregnant. For years she was building up to eventually getting pregnant. And then she got pregnant, and then she had the most terrible miscarriage. Like it wasn't, she was hemorrhaging. She lost units of blood. Then she had to go into the emergency room in this massive, big city, just unpleasant. Then she gets put on the conveyor belt of an ER. And, poor, like she was hemorrhaging. She was bleeding through the sheets. She wasn't getting any care from the nurses. Nobody was paying attention to her. They were just in the middle of a busy ER. And from that miscarriage, she no longer trusted her body. Like she literally could not trust that her body could support her because it was so traumatic. And, she had a lot of views of what it meant to be pregnant and be a mother. And now her body just completely failed her. And from that miscarriage, she wasn't able to root from that point on. And she came in, she happens to pop into Oregon. It's my practice. She has family here, so she'll come visit. I'll see her in the office a couple times a year. And she's a little bit anxious. And so I convinced her to do a pelvic block or that pelvic injection. And first she started crying. And then she got really quiet. But after that, she actually felt rooted in her body again. Mm-hmm. There is something about these injections, and Procaine in particular, that resets nerves that can get shut down for a lot of reasons. Emotional, infectious, traumatic. It is a very powerful tool.
Yeah, absolutely.
Well, I'm curious, do you know, are there other, when you do trainings, have there been other psychiatrists or, mental health workers in specific that have done your trainings, or is it mostly other physicians? And do you think that this, your trainings help them to be able to understand that mental emotional piece better about healing?
Yeah. So far I have a privilege to be, as far as I know, the only psychiatrist in North America who is doing neural therapy.
Is it because neural therapy is contraindicated in psychiatric disorders?
No, because nobody knows what neural therapy is. Number one, the stellate ganglion injection, which I mentioned, is done by anesthesiologists. As far as I know, there is at least one psychiatrist, probably more, who are doing this stellate ganglion injections, getting training from the anesthesiologist, using all the equipment, using a long-acting local anesthetics.
Marcaine?
I think Marcaine, right. And when I read about it, one of the side effects is seizures. And then basically, and I thought, my goodness, I've done hundreds of those, never ever seen it. And all the whatever effects that you can get, and people ask, oh, how come I don't see well? Thank you, I did a good job. So it basically, it's expected that you're not going to see well, but for 20, 30 minutes, and then the effect is gone. So, and And for them, when they do this injection, it lasts several hours. Another interesting thing, when they do these injections with the long-acting anesthetics, they randomly choose which side they're going to do it. So, and in the studies that they did, and there are quite a few studies published now, that's what attracted my attention. In the studies, it shows that basically the effect is there when they do this injection, and they do it just a couple of times. However, the effect was not strong enough for veteran administration to approve it as a mainstream therapy for veterans, which was kind of strange to me. And psychiatrists are just not there. When I do my muscle testing exam, I would always examine which particular site I need to inject. And it can fluctuate depending on where the most physical or mental injuries are, or or maybe depending on the time. Because the same patient, I may do one day left side, another day right side. So
maybe I'm wrong, but the studies that I've read and the persons that I've spoken with who have actually gotten the stellate ganglion block, seems like it works, but only for a certain period of time. Like I've heard anywhere from like 6 weeks to like 12 weeks. And then a lot of times they feel like they have to go back in and have it done again to have the same effect. Is that what you've read?
Yeah. That is accurate. That is accurate. It's basically, that is accurate so far. And it does work for limited amount of time, and I use it together with the emotional work, so it helps to alleviate. But what's happening, we store the traumatic memories kind of one on top of another, and until you resolve all the layers, it can be quite a few of them. So it's not a perfect therapy, and it works better when there is a kind of when somebody did not went through a traumatic childhood or something. If something bad happened since somebody was a kid, and one memory on top of another, and one trauma on top of another, so it's kind of, you need to peel a lot of layers of the onion. So if it happens just one car accident, and after that you become paralyzed, or like in your case, this particular incident where when in emergency room there was no help. So that is one incident that becomes easier to resolve. Unfortunately, I don't see many of those. They don't come to me. They come to me more complex ones. And then it becomes a longer time.
I'm curious, do you, because I always wonder about, the difference between doing the block where you're actually giving these like 3 different anesthetics, and then neural therapy where we're using much lower doses of just procaine and not using ultrasound to get exactly to the ganglion, but really just sort of filling that space around the ganglion. And I wonder if how we're doing it helps to facilitate a longer healing process, especially because we are utilizing a lot of these mental emotional techniques to kind of help release things. So I guess that's kind of what I've seen is when I've done the stellate ganglion, I feel like it's lasted a lot longer than 6 weeks to 12 weeks for patients. I'm wondering if you've seen the same in your practice.
So I'm at disadvantage because I use only procaine, so I have no comparison with anything else. And then my another disadvantage is that I see pretty complex psychiatric patients, many of whom on multiple psychotropic medications, which quite often block the effects of whatever you do. recently what I began, because I see that I would love to do it in one session, but it doesn't work. So recently what I began to do is to combine neural therapy with ketamine-assisted psychotherapy.
So to explain to us what that is, just because people might not know, what is ketamine-assisted psychotherapy first? Because I know this is going to be a story that I'm not going to be able to tear myself away from. I'm listening to it and I'm like, Papa, how have you not written a book yet? This is ridiculous that you haven't written a book yet. So, okay, so what is ketamine-assisted psycho? So just so the audience knows, I have a rule with my dad. My dad and I both have hyperbolic personalities. And when we discover something new, we will immediately, both of us, tell you this is the thing that's going to change everything and cure every ailing person out there. Both of us have this tendency in our personalities. So I have a rule with my father where I don't want to hear about the latest thing that he has done until he's been doing it for 2 years and it's still there. And if he hasn't been doing it for 2 years and it's no longer there, I do not want the machine that he wants to pass down to me. That is the rule in our family structure. He has been doing ketamine-assisted psychotherapy for how many years now?
Now, this one I've been doing for about for close to 5 years.
That has validity for me. I'm willing to discuss it.
Okay.
So what is ketamine-assisted psychotherapy to start with? Because it is having a moment currently.
Yeah. I'll do it in a very short way. Actually, this is actually well recognized by even American Psychiatric Association. So and actually in the latest issue there is a whole big interesting article. Basically, so what is coming to psychiatry since about 2000s that psychedelics do help in treatment of psychiatric patients. However, since the Nixon years, all the psychedelics had to go into the underground, become very, very illegal, Schedule I drugs. If you are using them in your private practice, you're going to be in jail. So be careful, except one, ketamine. So ketamine is a general was marketed as a general anesthetic in the mid 1960s. However, what was noticed right away that it has a very different effects than from all other general anesthetics. And many people who would come after the general anesthesia would say, "My goodness, my depression is gone." So, but then Nixon years, it went all kind of underground. And then all big institutions in the year 2000 and so began to investigate it, primarily giving it intravenously. And it was noticed it was working for treatment-resistant cases, meaning depression, anxiety, PTSD, which did not respond to conventional medications. And then I was, when I began to learn, I don't like to do it IV, so I learned how to do it in a different way and giving the first injection intramuscularly. And after giving ketamine intramuscularly, and actually, I need to say it's a very safe medications. Very, very few, God bless you, very few negative effects. And when you give it intramuscularly, the patient go to either to state of light relaxation, depending on the dose, or to more significant relaxation, or to dissociative state. And when patient go to dissociative state, if you work with the patient before and you know his issues, you can actually work with him through the issues, guiding them, or while they're listening the music, they begin to resolve the issues. And there is now significant research that that ketamine in multiple forms, and primarily it is investigated as given intravenously without any accompaniment with psychotherapy or whatever, helping them to resolve their traumas by guiding them. But even doing it intravenously helps them to resolve a lot of issues. And there is a strong research coming that people connections in the brain begin to feel better. People mood improve. People anxiety goes down. So it's a very helpful method. So ketamine-assisted psychotherapy can be done in a number of ways. Can be done the first time. It's usually done in the office, where you give it usually intramuscularly. However, you can give it orally, or you can have it as a spray or as an inhaler. And then basically, or you can, if you trust the patient, you can give them pills, and they do it at home 2 to 3 times a week. But you need to guide them how to do it. The addiction potential is pretty low, but it exists, so you need to be very careful with that. So in my close to 5-year practice, only one patient began to use it in a kind of non-prescribed matter. She was not addicted, but she was using it every day. That's not how I instructed her. So I had to cut her off.
So how are you pairing that with neural therapy? Can you explain that for us?
Okay, so I'm lucky. I have now kind of a lot of space in my office. So I would have a patient I would examine first. I would know what to inject. I find the main emotions I need to deal with. I would put patient in the separate office. Will set up a music for the patient. I would do my set of neural therapy injections. And then when injections are working, I would give patient the injection with ketamine, put the music on, and they are going through their journey, and I guide them where to go, what needs to be resolved. And then I do my own work. I work with my other patients. Then in the middle, when I have a break or whatever with my patient, I come there. How are you doing? Where do you stand? Guide them again, and then go do my job. So I don't need to overcharge them. It becomes a reasonable in terms of what they need to pay, and it becomes very effective.
What are you noticing is the outcome?
So basically, the people able to resolve, I think, their issues much faster. So it kind of it gives them more opportunity to go into deeper emotional work. I need to take a step back. When I do neural therapy, including I usually give them about 2 to 3 cc of procaine intravenously. I inject around the thyroid gland, and usually I do number of injections in the body where they hold their emotional stress. So after I finish my stuff, an injection doesn't take me long, maybe 5-10 minutes. All the injections done in not more than that. And after that, people go into this state of semi-consciousness, in slight dissociative state. In this state, they're very much able to, hopefully with my guidance, to get through the emotional traumas that they've been carrying for a long time. Some of them want to talk to me, and when I ask, some of them I feel like they just need to kind of to go through their process as they're there. Whatever it is, I need to feel where they are, and most of them like to stay there for a long time. Some of them, after a few minutes, I'm ready, and they want to go. So it's depends, but most of them like to go into this state of relaxation. Some of them go through crying and complaining and whatever it is, and after I have this one patient that I've been seeing for some time. So after some time, she just kind of she just falls asleep, and I can leave her there.
That's a pretty profound change for patients.
for many of them. But just once again, for some of them, it's a very fast. And for some of them where the multiple traumas, it takes time.
And you find that when you pair these techniques in your, tertiary care psychiatric practice, it's not like the primary cares haven't helped these people, the standard psychiatrists haven't helped these people. You're really a tertiary care psychiatrist. Like these are the most treatment-resistant patients that you have. So with that population, you feel like this gives you a footing.
Right. And I kind of, my wife is a psychiatrist too, and so her patients stay with her for 30 years, So I have very few patients who stay with me for 30 years. So I don't like keeping people on medications or whatever. My goal is to get them well and forget how to spell my name.
So when
that's what gives me kind of fun.
When are you going to publish your papers on this?
He's been publishing. Actually, just a little aside story. I had a doc come in and rotate through with me who's a gastroenterologist, and she's in an alternative medicine. It's not IFM, but it's like a similar program. And she was like, I'm reading this paper by Dr. Michael Gurevich. Is that your father? So he's been publishing for years. I think it's time you publish a book.
Ready for that in my next life.
Oh.
I'm going to learn how to write.
How about in your next decade? Not your next life, ever your next decade.
So,
thank you.
Yeah, thank you so much for talking to us today about this. I didn't even really think about ketamine, but of course it's an anesthetic. So it's like you're utilizing two different anesthetics in these very different ways together for patients to be able to reset those nerves, which is amazing.
Will you let people know how to find you? How do they find you?
No, I mean they can Google my name, Michael I. Gurevich, MD. We have a website which we don't particularly maintain, transformational healing.Me. Or I still have my old website. It's holisticmd.org. My office number 516-674-9489.
That number is so imprinted in my childhood memories.
That's where you are too. You're in New York.
I'm on Long Island, New York, in Glen Head, New York. And you're welcome to call, and I would be happy to. Usually, before patients become my patients, I need to have 15 minutes interview with them to see if they would feel like they like to work with me, or if I can work with them. So I need to know. And so that's all. I want to wish you ladies success in your endeavor, because I think you're doing a wonderful job, and we need to let people know what neurotherapy is. And I wish you a lot of luck.
That's our goal. Our goal is to let providers know that there's this very simple, very available, a lot of different clinical conditions tool that you can implement in your practice like that.
Yeah.
So
exactly.
Thank you for being our first interviewee and being patient while we work out our technology too.
Please do. Okay, great. Thank you.
Thanks,
everybody.
Thanks, Dr. Gurevich. Bye.
Okay, thank you.
Thanks for joining us today. If you like the episode, please like and subscribe to our channel and review us on your podcast players. Also, if you think this episode is helpful to some of your friends or colleagues, please share it widely. If you are curious about learning about neural therapy or other injection techniques, check out our courses on learn.Neuraltherapy.com. We'll see you next month for our next installment of the Point of Medicine podcast.